All right. Good morning, everyone. Welcome to today's lecture by Dr. Christopher Mushquash. We're very pleased to have him here as our scholar for the 2023 Canada Gairdner Momentum Award Lecture. It was kind of neat. We were just visiting, and our families are from the same community in Dilico, Ontario. So we were just sharing a little bit about those familial connections. As we begin today's presentation, I just want to give a brief introduction to myself since we are online. Welcome to the University of Winnipeg Collegiate. My name is Dr. Kevin Clace. I am the Dean at the Collegiate at the University of Winnipeg. As we begin today's session, we're going to start with our land acknowledgement. So the University of Winnipeg is located on the original lands of the Anishinawbe, Cree, and Dakota peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories, and we acknowledge the harms and mistakes of the past. And we dedicate ourselves to move forward in partnership with Indigenous communities in the spirit of reconciliation and collaboration. And that is very heartfelt today with our speaker as well, because Dr. Mushquash is a First Nation scholar who was born and raised in Northwestern Ontario. As I mentioned, we're actually from the same community. He's Anishinawbe, Ojibway, and a member of the Pawgwasheeng, Plat First Nation. Dr. Mushquash is a professor in the development of psychology at Lakehead University and the Northern Ontario School of Medicine University, clinical psychologist at Dilico, Anishinabek Family Care, Vice President Research at Thunder Bay Regional Health Services Center, and Chief Scientist at the Thunder Bay Regional Health Research Institute. So he comes to us with a plethora of background and experience in his field. He's also the Director for the Rural and Northern Health Research at Lakehead University and is a Canada Research Chair in Indigenous Mental Health and Addiction, with expertise in rural and northern clinical practice and the development of culturally appropriate interventions for mental health and addictions difficulties in First Nations children, adolescents, and adults. Dr. Mushquash champions culturally and contextually appropriate mental health and substance use services for Indigenous communities. His high-caliber work has improved the lives of many Indigenous communities and influenced national mental health and addiction understandings as he brings together Western and Indigenous methodologies. His team conducted the first Canadian study of adverse childhood experience in First Nations adults seeking residential treatment for substance use difficulties. The outcomes enhanced understanding of the nature of developmental and intergenerational trauma in First Nation people and improved clinical care for those with substance use difficulties. His research has also upended conventional understandings of mental health in Indigenous families and established best practices for engaging Indigenous people in research. Furthermore, his research has directly influenced federal funding policy in remote First Nations communities. As a leader in his field, Dr. Mushquash has advanced mental health across Canada, garnering various awards, honors, and appointments in recognition of his research and clinical expertise. His devotion to the profession and Indigenous mental health can be seen in the impact of his work in changing Canadian policy, educating professionals, working with First Nations people, and more importantly, bettering the quality of life and care of many Indigenous youth and community members. Please join me in welcoming Dr. Christopher Mushquash.
Thanks so much. That's a really, really kind introduction. It sounds like a lot, but I think in reality, I tend to think about my job as sort of all the same thing, and so I'm a kid that a native kid that grew up in Northwestern Ontario. Really sort of saw the effects of mental health difficulties and addiction in my own community, my own family, and really thought about just trying to be useful, just trying to find a way to help with that, help find a pathway forward on that. So I just want to thank you for the introduction. It's very nice. I didn't write that, so it's interesting to hear it as being read. What I will say is, how I want to start is to acknowledge the people out there on webcast. I don't know how many people are out there, but thank you again for tuning in. But I also want to acknowledge everyone here in the room. Quite an outstanding group of people. And I want to thank you all for being here, but I also want to thank you for the tremendous amount of capacity and the tremendous amount of potential that exists in the room. Who here wants to go to university, right? Who here wants to pursue a job in the helping type professions, nursing, medicine, mental health, a lot, right? The things that you will see in your lifetime, the advances in your careers, and the advances that you'll make in helping us all move things forward are going to be massive. And there's no real way of predicting that or even knowing what your capacity is until you push it and you stretch as far as you can. And it's also important that you're supported in that, right? That you have a community, that there's people around you who have your best interests in mind, and that you're surrounding yourself with people who care deeply for you, who want to make sure that you do well. Those are all essential parts of moving forward in a good way. There's a lot of ways to think about it. One of the ways that we tend to think about it now in larger conversations around mental wellness in First Nations communities, in some First Nation communities, but also more federally in terms of research and clinical care, is through understanding that culture and identity and wellness are very, very important and closely linked important pieces of our paths. We often talk about it in terms of hope, belonging, meaning, and purpose. That is, the way to continue to be well or the way to heal when we're unwell requires those four things. One, that we're hopeful about something, that we're hopeful that the world holds something for us, holds something for our families, that we have the ability to make something better, that we belong to a community, we have friends, we have, families, we have others that where we feel like, we belong. That it means something, that you are energized by it, that you do it and you're compelled to do it, you're pulled forward rather than pushed into it. And that you have a purpose each day when you wake up. And so many of these things are among the things that get undermined in many, many lives when we are contending with difficulties in mental health, when we're contending with difficulties in addiction, and when we're contending with just difficulties related to the challenges of life at times. And really, it's in the balance of those things that allow us to walk that path in a good way. So I just want to say, to all of you here, Chimigwech for that, and for what you'll bring. Part of that is a cultural orientation toward understanding that life is ought to be understood in sort of a 7 generations type orientation. That is, that we aren't just necessarily discrete individuals, but rather we are individuals that came from a long line of other individuals, and we also have a responsibility to those individuals who will come after us. And so I'm often asked, why did you become a psychologist? And that's an interesting question, right? If I ask anybody, tell me about yourself, you're going to tell me about yourself in a specific way. If it's in a clinical interaction, you're going to tell me what you think I need to know that's clinically relevant. If we're just meeting as friends, tell me about yourself. You're probably going to tell me about things you're interested in or things that you like to do, to see if there's any kind of shared interest that we might have that might kind of, get us on the same page. So the answer to that question becomes sort of bound by the nature of the relationship with the person that you're talking to. And that's an interesting thing about it. And so when people ask me, what is it, why did you become a psychologist, or how did you become a psychologist? Well, the answer to that is, I got a Ph.D. in clinical psychology, right? But then you go backward, and how did you get a Ph.D. in clinical psychology? Well, I got an undergraduate degree in psychology. And how did you do that? Well, my marks were good enough in high school. And you can always think of those answers, and you can go backward and backward and backward until you kind of distill down what it is that got you to where it is that you are. And I always say that I accidentally became a whole bunch of things that I never knew existed. So I didn't know what a vice president research is or what a chief scientist is. I didn't know what a Canada Research Chair was. I didn't know what a professor was. I certainly had never heard of a psychologist. You know, in where I'm from in Northwestern Ontario, I didn't know anybody who went to university. I didn't know anybody whose parents went to university. It's likely that some of my teachers had gone to university, but not all of them, because at that time, your teachers didn't necessarily have to go to university to teach. In fact, some of my teachers had taught my mom. They'd been teaching for a long, long time. And so when I was in high school, it turned out that I was reasonably good at some of the academic stuff. But I didn't go to high school for the academics. I went to high school because my band was there and my friends were there and my hockey team was there and the other things I was interested were there. And I incidentally learned some math and I incidentally learned some biology and some chemistry, and it turned out I was pretty interested in that. But when I was about grade 11 or 12, somewhere like that, I spoke to my guidance counselor and he said to me, well, Chris, your marks are good enough to get into university. You can either do science or English. What do you want to do? And I said, well, I barely speak English. I mean, in Northwestern Ontario, we tend to have a version of English that's not necessarily formal English. But I kind of like science, so maybe I'll take that. And he said, well, you can take science with math, and that's called biochemistry, or you can take science without math, and that's called natural science. And I said, well, I don't mind math, maybe I'll take biochemistry. So then I went to university for biochemistry, and that's what I thought my choices were. And I got to university, and I lived in residence, and the first thing I did was met a whole bunch of people taking a whole bunch of other things that I'd never heard of. Anthropology and sociology and psychology and philosophy and outdoor recreation, parks and tourism. And I learned that there was like a tremendous amount available that I'd never heard of. And so I found myself in university the first couple of years doing what people in their first and second years of university typically do. That is move around between courses, try to figure out a bit of a pathway. And somewhere around second or third year, I found a psychology course. And I took an intro to psychology course, and I found it very, very interesting. To me, it had like science and neuroscience and brain, but it also had development from child. It had mental health difficulties and addiction. It had statistics and research, and all. It just kind of had like everything. And I began to think to myself, well, maybe this is something that I could learn about to be more useful in my community. And so at that point, I pivoted to psychology, and I began taking those courses. I also decided I might like to try a job in research. So I looked and I found a research assistant job at the Center for Rural and Northern Health Research. I'd never done anything in research before. In fact, I think I'd only taken an Intro to Research Methods course in university. And I applied and I interviewed with all these Ph.D.s. And somehow I got the job. And I started working as a research assistant at the Center for Rural and Northern Health Research. I'm the director of the Center for Rural and Northern Health Research now, in a bit of a full circle kind of story. And then I got through my undergrad, and I was working closely with a professor doing research, and he said, maybe you want to do a master's degree. I'd never really thought about it. Okay. And then I was doing that work, and it was going well, and I met another professor who said, maybe you want to do a Ph.D. in clinical psychology at Dalhousie University in Halifax. And I said, really? Like, I'd not applied. I've missed the deadlines. Like, I might like to do that. I don't know. He said, well, send me your application, and we'll have a look at it. And but make sure you do it by Monday, because this was like a Thursday or Friday. Get everything together, and we'll look at it Monday. And they did, and they actually really gave me a chance. And so I went to Halifax, and I took a Ph.D. in clinical psychology. I'd never really been, I think I'd visited once there for a couple days. And so that's how I became a psychologist. But the interesting thing about it is that's not how I became a psychologist, right? I talked about those stories go back and forth. And here's how I actually think I became a psychologist. When I was about 6 years old, or 7 years old, my dad sent me in the bush by myself when we were hunting. And so why did that make me become a psychologist? Well, here's why I think. So when I was a kid, I was a bit of an anxious kid, right? I had a lot of physiological anxiety, sore stomachs, nervousness. That's kind of how I was. And my dad, he was, still is. He's First Nation. He grew up. He didn't go to university. He grew up kind of, on reserve, and then in a small town beside the reserve, and he was on the land a lot. And we were hunting one fall, And we got to this place where we hunted, and there was this place where the trail broke off, and he said to me, I want you to go that way. And I looked at him like, by myself? He said, yeah. And off I went. And I was probably crying and I was sweating, your head's pounding behind your head when you're nervous by yourself in the bush. Anyone ever been nervous like in the bush or at night or whatever like that? And there's like a squirrel that walks by and it sounds like a dinosaur. It just sounds like it's smashing trees down. And then you look and it's like a little thing, And I get to the other end and I'm probably crying and I see down the trail my dad's orange vest. He didn't even wait for me and I'm catch up, I get there and then we probably get home and my mom says to him, why is he crying? Why is he so upset? And well, Dad sent me in the bush by myself. And anyway, we went hunting again. Next time we got there, he sent me that way again. And I knew he was I was getting to that spot and I'm going, he's going to do it again. He's going to send me by myself. And he did. And the next time he did it again. And the next time he did it again. And by about the third or fourth or fifth time we got there, him and I got to that spot and I told him, I'm going to go this way. And I went off by myself in the bush. Because I wasn't fearful of it anymore. Now, again, my dad's not a psychologist, but many, many years later, I'm doing a Ph.D. in clinical psychology, and what I learn is that the treatment for almost everything includes some aspect of exposing yourself to things that you find difficult or find distressing in a supported way, such that you learn over repeated opportunities to have that experience, that it's something that you're capable of doing. And there's a whole lot of parts that go into that. You have the physiological reaction, and then the physiological reaction goes down. And the next time you go, you don't get as nervous because you have a sense of what's going to happen. And the next time you don't have a sense, you don't have as much anxiety, and then eventually you're not anxious about it anymore. Think about that for almost anything else you do. Who here has played a musical instrument at a recital? Anybody? Right? The first time you're ever at a recital, you get up there, it's quiet like this, and then your feet go across the stage, and everyone's looking at you, and you sit down behind the piano, and then you pull the bench, and it makes that loud noise, right? And you're shaking. But then the more and more you do that, you sit down in front of people, and off you go. Who here's an athlete? Ever been to some type of event, and you're really nervous about it? And then all of a sudden, the event starts, and you're nervous for the first little bit, and then your nerves just come down, and you settle into that thing that you're meant to do, whether it's a hockey game or a basketball game, or it's running, or some other swimming, some other thing like that, right? Those are all exposure experiences. And the reason why you see professional athletes and others, musicians and artists and singers and all these people get so competent is because they've done it so many times that they know how to manage the anxiety associated with it, such that their skill can shine through. And so my dad wasn't a psychologist, but from a cultural standpoint, from a traditional standpoint, he knew how to treat anxiety in young people. So whether it was his elders who taught him that. And the thing that clinical intervention, but was really a cultural intervention, the thing that did was it also helped me manage anxiety, but it produced increase in self-efficacy. That's your belief in your own ability to do something. It also increased my ability to kind of try new things and be able to tolerate what might happen. And so when I go back, it was like, well, I went to university the same way. I didn't know what it was. I didn't know, right? But I went that way. And then I changed programs. And then I got a job as a research assistant. And then I went to Dalhousie. And every time it was sort of like, that lesson from the bush where I knew I had to do something that was probably difficult, that I was uncertain about, that I didn't know how it was going to turn out, but that made me feel anxious. But I knew that if I didn't do it, I wouldn't get any better at or have the opportunity to have something new. And so when I say I sort of accidentally became a bunch of things I didn't know existed, it's true. All of a sudden I'm finishing a Ph.D. and I actually did my residency here in Winnipeg at the University of Manitoba. I was in the College of Medicine for 6 months at the Health Sciences Center, and then I was in Flin Flon for 6 months. Anyone been to Flin Flon? Yeah, Flin Flon's awesome. I still have friends there. And then I got a job as a professor. And then it turns out that there's like different ranks of professors, right? Like assistant professor, that's when you're new. And then you go up for tenure, and that's an associate professor. Then once you've accomplished enough in your career, you can go and be a full professor. And I didn't know any of that. I didn't know that there were Canada research chairs. I became one of those by accident. And then I was doing that job for a while, and I was getting some things done. And somebody asked me if I might be interested in being a chief scientist at the hospital. And I tried that. And so in those early lessons, those early developmental lessons, what I found out was that there's important cultural knowledge, there's important cultural approaches to being able to manage those things that seem too difficult in the moment for us to be able to do by ourselves. And in doing that and not avoiding it, you begin to increase your capacity more and more and more. And so I started the talk today by saying thank you for all of the capacity and potential you have, which you don't necessarily know what that is right now. So you're going to have an exam period at high school, and it's going to be stressful, right? Because it's going to be the most challenging thing that you've done academically up until that point. And then you're going to get to undergrad, and it's going to be a little bit more challenging. And you're going to look back at high school, and you're going to say, man, I sure wish I just had my high school exams to do, right? Because now your capacity is increased. And then you'll have an assignment to do. And then maybe you'll go on to become a nurse, or you go on to become some other professional, and you have all these things to do. And every time you're at a new point in your life, you'll be able to look back at kind of where you were before and say, the things that I'm able to do now, if I would have asked 14-year-old or 15-year-old myself, do you think you'd be able to do those things? The answer to that would be no, right? Because you have no real way of seeing into the future in that way. So then the thing that we can do is challenge ourselves in those new experiences and surround ourselves with community, family, and supports to be hopeful about what the outcome's going to be. Find those things that provide meaning for us in life, and make sure we wake up each day and have a purpose, that we have something to do. So we know that mental health and addiction difficulties are things that we see more and more. There are things that are in our communities, they're in our families. People are really having a difficult time. We see it when we're walking down the street. And the opportunity to help support people is massive. There'll be more and more help that will be needed. In Ontario right now, so I live in Thunder Bay, just across the border, there's about 4,000 clinical psychologists. My understanding is that within about 5 to 10 years, there's going to be 2,000 clinical psychologists. Well, why is that? Well, people will be retiring. The average age of that profession is a little on the a little nearing the later part of careers. And if you look at other professions like nursing and medicine and other things, that's also the case depending upon where you look. So 4,000 psychologists now, down to 2,000 in 5 to 10 years. Like, if you thought it was difficult to find a psychologist now, just wait a little bit, right? Unless we produce a lot more, right? And what that means is there's a lot of opportunity. There's a lot of opportunity for us to pursue those things that we want to pursue, those things that we're interested in. One of the other challenges that I sometimes see for young people is that there's the opportunity to connect with people more and more and more, particularly socially on social media and so on, but that the level of isolation that people tend to feel increases, right? So we have a lot of people that we're friends with on social media, but fewer people who we feel that we're very, very close to. That could present a bit of a challenge. Finding community, finding those like-minded people, finding people to meet and go out and see and experience things and try new things and practice, that has to be balanced in both environments, in the online environment, but also in the home environment. Sorry, the online, but also, what do you call non-online life now? I don't remember. They used to call it, what they used to call it? Like, I don't know, they used to call it the real world, but now it seems like more online is considered real world. Because there's so many experiences out there that are available to us that that we have to have. And if we don't have those things, a couple things happen. The first thing is we become unsure about whether or not we'd be able to do it. And that's something that can slow us down. But the other thing is part of very, very normal development. That is, we're always trying to grow as we get a bit older. We differentiate ourselves a little more and more into individuals, right? We develop our identities. We learn more about who we are, what we're interested in, what we like. And so the important piece about that is that natural process has to happen in the context of lots of different experiences, so that we can fully see all of the parts of the world that we may have an aptitude for, that we may have an interest in, that we may have never considered, that we may have never been exposed to. And those things can only happen in certain experiences. And so we want to be sure that we're always identifying and developing our identity around our most adaptive aspects, the things that we're strong in, rather than our deficits and the things that we're struggling with. So my Ph.D. research looked at this, right? So some of the stuff that we were doing was we were developing alcohol interventions for young people in high school, people who were deemed at risk of having alcohol-related problems. And it turns out, in the psychological way of knowing things, there's a number of reasons why people can be at a greater risk of developing an alcohol-related problem. And some of those have to do with things like anxiety. Some of them have things to do with depressive feelings and impulsive behaviors and so on. And there's whole evidence-based interventions to help support young people who are having difficulties in those areas. And they work really, really well. When we were doing the work with First Nations, it was interesting because we spoke to many cultural people and elders about the nature of some of these, what were perceived as being risk factors from a psychological literature. And what our elders told us was that, our way of understanding those things is not through risk, but through capacity. So, for example, the person who was anxious, who was at risk, let's say, wasn't necessarily at risk. What that person had to do was understand their unique gift, and their unique gift was they could hear in their body things that weren't perceptible by other people, dangers, concerns, and they could feel it in their own physiology. And that's a capacity, that's a real strength. It only becomes a challenge is if we don't find the way to harness the strength, we don't find a way of managing our uniqueness and to utilize it as a capacity. Similarly, with our young people who had a tendency toward thinking very hopelessly, our elders said these are our introspective ones. These are our problem solvers. They think deeply about things. In fact, they think so deeply that sometimes they get into a way of thinking that they can't see a way out. So that's not a limitation. That's a tremendous strength. But we have to show the kids the young people how to use those strengths, right? So much of what we have that can seem like a capacity has the ability to be a limitation as well, and things that we understand might think is of a limitation have the potential to be a capacity and a strength. And so finding the way of identifying those in ourselves, being supported in community, and identifying with them in an adaptive way, thinking through how we use our unique capacities as strengths to motivate us forward, become very, very important parts of just growing. There's lots of ways into careers in mental health. There's such a vastness in careers, right? Not everyone has to be a clinical psychologist. Not everyone has to be a psychiatrist. There's counselors. There's caseworkers, and there's occupational therapy workers and rec therapy workers and music therapists and so great many people who are all contributing to the larger system of supports and services that we try and build out for people. That the thing that always struck me was that if you wanted to work in the field, you could work in the field probably in almost any way that you wanted that aligned with some capacity that you have. Art therapy. There's like equine therapy. You know what that is? It's where people who keep horses have programs for people who are struggling with mental health and addiction difficulties to come and care for horses and ride horses, right? There's like almost anything you can imagine. And so what is about all those things that contribute to wellness? Well, I think the thing about it is that engaging in all those different experiences, makes us hopeful. It gives us a place to belong. It means something to us, and it gives us a day-to-day purpose. And those are so many of the important pieces that we need to find for ourselves and make sure that we have. Very often they're available within our families, within our communities, within organizations and structures and institutions like this one, who are really trying to foster all the tremendous capacity and potential that exists here in the room today. So I know this talk is meant to be about 30 minutes with some conversation. I'm happy to answer any questions that you might have about how to go about being a psychologist. I'm happy to answer any questions that you might have about mental health, about addiction, about Indigenous health and culture, and anything else that you might like to talk about today. So again, Chimigwech for the opportunity to be here with you.
You have a question, we'll get you to raise your hand and I'll pass you the microphone and you can ask your question directly into the microphone. Shakur, you have a question? All right.
Here we go.
What set apart psychology for you from psychiatry?
That's a great question. So does everyone know the difference between psychiatry and psychology in terms of pathways? Right, so that's something that a lot of people might be unfamiliar with. So it's a wonderful question. Thank you for thinking about that. So a psychiatrist is a mental health doctor who has a MD, so like a physician. Okay, so that person goes and does an undergrad degree, then goes and does the MD, which is another undergraduate degree in medicine, and then takes on psychiatry as a specialty. Do you know how there's other specialties in like maternal and dermatology and radiology and diagnostics, and there's all these different specialties? Well, psychiatry is like one of them. Okay, so it's a medical doctor that becomes a psychiatrist. A psychologist is a little bit different. A psychologist does an undergrad in psychology and then does a Ph.D. in clinical psychology. And the Ph.D. is a different degree. It's a graduate degree where you're trained to do clinical work, so assessment, particularly like psychometric type assessment. So you're trained in clinical interviewing, certainly, but you're also trained in measures and forms and all the statistics and things that go along with that. You're also trained in intervention, so evidence-based intervention. So you learn how to do therapy with people. Cognitive behavioral therapies are one of the ones that we learn a lot about. So you'll hear about CBT, DBT, you'll hear about a number of different modalities now. But you also do research. So you also do different research projects. So you'll have a dissertation that is a series of studies that you're trying to find some new information, some new knowledge. You're trying to uncover something that might have not been known before, and then you have to be able to do that effectively. Physicians have a bit of a different pathway. So they will have, in psychiatry, they'll have like a research rotation, but it's not necessarily the same as a master's thesis or a dissertation, a PhD thesis. They'll do lots of clinical work. They'll take their courses. They'll learn all about the medications and so on. And so some of them will take other specialties in therapy. Some of them will take some other specialties in other areas. But that's kind of the predominant thing. I thought about med school, but I think I was more interested in learning things from a psychological perspective. I was more interested in learning all of the skills for research, because I really saw research as an opportunity to help improve things in our community. So that happened to be my pathway, but it's a very good one. And it's not uncommon for psychiatrists and psychologists to work very, very closely together. So I had, in my clinical work, we had a psychiatrist who was fantastic. Him and I met every Wednesday morning. We discussed cases. We brought our different perspectives together to try to find the best services, the best pathways for people. And so both very, very important, but different fields of mental health. Yeah. But thank you for the question. It's a very, very good one.
Awesome. Any other questions for Dr. Mushquash?
Which one right at the front? You want to use this mic? Usually what I always like to joke, I say, oh, glad you sat here. I always need volunteers. No one likes volunteer.
How many years did it take you, to become a psychiatrist?
It's a great question. So I did an undergraduate degree, and that was 4 years. So that was an honors degree, and that's about how long most honors degrees are in university. So that's 4 years. I did a master's degree, and that was 2 years. You don't have to do a master's degree to be a psychologist. You can go straight into PhD. Most PhD programs on paper are 5 years long. So my wife, for example, she's a psychologist as well, and she did her undergrad, then her PhD, and she did her PhD in 5 years. So she was in university for 9 years altogether. I was in university for 13 because I did a master's degree, and then I took a little longer to do my PhD. My wife's smarter than I am, so she got done quicker than me. But yeah, it was 13 years for me, but it doesn't have to be 13 years for everybody. The quickest you can do it is 9 on average. Yep. The interesting thing about graduate school, though, so once you're done your undergrad, it's 4 years. It seems like a long time. It's really not a long time. Once you start doing a master's or a PhD, you're doing things that you're interested in. You don't have as many courses. The courses are specific to things you're interested in. You're usually working as a graduate assistant. So what that means is you might do marking assignments for undergrad courses. You might even be teaching the odd lecture or other things if you'd like to, but you're also doing your own research. So it doesn't so much feel like you're in school anymore as it feels as though you're learning all the skills you're going to need in the job when you're done. Right? So it's a bit of an apprenticeship type way of thinking about it. But again, it's an excellent question. 13 years seems like a long time. Anyone here 13 years old? Yeah, right. Seems like a long time, doesn't it? Right? My whole life it's going to take, right? But think about this. Like I was thinking about this the other day. So I happened to be in Toronto last week for meetings like this, and I met with high school students just like this. And I brought my son, and the reason why I brought my son, he's 7, and we went and saw a hockey game. And the hockey game that we saw was Chicago versus the Toronto Maple Leafs. Does anyone know the new player on the Chicago Blackhawks that everyone's watching? Anyone? Yeah, and how old's Connor Bedard? 18. How long has Sidney Crosby been in the NHL? 18 years. So Sidney Crosby's been in the NHL as long as Connor Bedard's been alive, right? So even though 13 years in university seems like a long time, as you get older, the feeling of time changes a little bit, right? So, you think about yourself, think of in 2 years, you're going to be in what, grade 11? Okay. Now, if you're 2 years old, in 2 years, you're going to be 4. That's half your life. But when you're 13, that's not half your life. That's only like a small part of your life, right? And the older and older you get, that couple years or year seems like a smaller and smaller part, because it is. It's just a math problem, right? Imagine being in the NHL as long as somebody else who's the new person has been alive. Yeah.
All right, any other questions? We have one right here. Pass the mic down.
By the way, the Leafs lost the game we went to, 4-1.
I wanted to ask if you could give us more details about the research you are working on right now.
Yeah, gladly. There's a lot of different things that we're working on. So one of the big studies that we have was described a little bit at the beginning, is in collaboration with First Nation organization where I work clinically, but also we have a whole program of research where we're doing lots of things. We're looking at data to understand what are the main presenting issues that young people get referred into service with. And what we're finding is that there's a lot of trauma-related things, a lot of depressive-related symptoms, and then a lot of acting out kind of symptoms. And what we're trying to do, and we've just run a treatment group at the end of August for young people the age of many of you in here, that takes the very best of psychological interventions and the very best of traditional Ojibway culture-based interventions and puts them together to give kids the best of both worlds, but also then we track and see how the kids do with respect to their symptoms. So that's one thing we're doing. Another thing that we're doing is really trying to understand how the nature of adversity that people experience in their childhood, so before the age of 18, contribute to outcomes in mental health and addiction difficulties. And we're partnering with people who are going to treatment centers for addiction treatment in that research. We're also, myself and Dr. Vidya Iyer, who's at McGill, are co-leading with community partners and many, many others, research looking at integrated youth services for Indigenous kids nationally, and helping to support the different provincial groups that are doing that kind of work. So we're talking all about data, what data need to be collected, what data are important for youth. So what information do you think it would be important for the mental health system or your clinicians or your other services to collect about you, to track how you're doing across time? We're doing research in areas like that. Really, there's a lot going on. It's hard for me right now to think of just all the projects, but those are some of the main ones that we're doing. And then I'm very, very lucky to collaborate with people who are doing all manner of research in everything from mentoring to treatment for chronic illnesses and disease, through to psychological intervention, modification, and so on. And so, yeah, I've been very, very fortunate to collaborate with many, many people across Canada. Yeah, but thanks is a very, very good question.
All right, we have another question over here.
In your career, did you see that the population that chose to access mental health services or like psychologists were diverse, or did you think that people of color didn't get to access mental health services as much?
Fantastic question. Yeah, absolutely good question. That's part of the integrated youth services that we're working on. So what we saw, what you're right, is that sometimes it can be the case that people who have more diverse experiences sometimes are less likely to access the services that are available for a number of reasons. Sometimes it's the case that in our communities, there may be a little bit of a feeling that if you have to go there, that you shouldn't really have to go there, kind of thing. Sometimes that might be the case. Sometimes it's the case that people have tried to go and been met with an experience that they didn't like, that wasn't very supportive or didn't feel right. Sometimes people have tried to access things, and when they attended, the information that they learned wasn't that helpful. Sometimes it's the case that just given where we live in our neighborhoods, the availability of services or the cost associated with them means that there's something that we're unable to access. So there's a whole bunch of reasons why, but your observation is a very, very good one, and it's something that a lot of people are looking at now nationally, is how to improve services for young people, but also adults from a great many backgrounds, including Indigenous people, but also including newcomers to Canada, including people from diverse cultural backgrounds in Canada, and there's still a lot more work to be done there, and there's a lot of opportunity for, again, people who have those diverse experiences to share and to engage and to be a part of the work. We are partnering nationally with a couple groups, and we are in the process of putting together an Indigenous youth advisory nationally for Indigenous young people to be able to advise on the work of the integrated youth services. And some of my colleagues working in other areas have similar advisories comprised of persons of color, young women, sexual diverse youth identity, youth with diverse identities, and so on, to help understand the perspective of those young people, so that we can do a better job at meeting the needs and meeting young people where they're at with the services that would be helpful for them. So again, another great question from you.
All right, I think we have time for one more question.
Yeah.
As a psychologist, what can you say about like the cost and things like that when it comes to, like for like including like diversity and things like that, like I'm sorry, I'm so bad.
No, this is good.
Does that make sense?
Yeah, like how can those barriers be reduced? Is that what you're asking?
Yeah, like people who can't afford it, like.
Yeah, so what can people do if they can't afford psychiatry services?
Yeah, that's a great question. So psychologists in general are in the private sector, and that's a bit of a challenge, but not to say that all psychologists are in the private sector. So for example, in Winnipeg at the Health Sciences Center, there's psychologists that work at the Health Sciences Center, actually quite a lot of them, on different services. And you probably have other hospitals, I know St. Boniface had psychologists as well, where you can go. The challenge with the public system sometimes is that it can take a little longer because there's more people waiting for those services versus people who have access to health insurance or who have the means to pay for a private service. And that remains a challenge. I think one of the things that a lot of people are advocating for is for clinical psychology to be included under more public funding models. And that's something that, you know, we can bring home to our families, and we can engage within our communities to ensure that our politicians are hearing those messages as well. We have the opportunity to advocate for those things. The cost of private services can be a lot, but there are also specialized clinics in some places, and I know that there are some specialized clinics locally that do different things, and some of those have what's called a sliding scale. And what that means is that they will they adapt the cost of the service depending upon the income of the person who's trying to access the service. And then there's some clinicians as well who will do some pro bono. What that means is like without cost work. So for example, you know, I have over my career probably about 5 to 10 different people that I've seen for a reasonably long period of time for psychotherapy where I've not charged anything for. I've been fortunate in my work to be able to fit that into my clinical day and been supported in doing that. But again, it's not I wouldn't say it's common. It's a little bit uncommon, but also it's the nature of the organization I'm in is very supportive in terms of trying to be as accessible to everybody regardless of means. So I think there's opportunities like that to engage with local organizations that may also have programs or consulting psychology that you can access even if without having to pay an hourly fee. But it's a great question, yeah.
Okay, just as we're wrapping up here, I have one extra question related to the questions on research.
Yeah.
That I think for us would be very unique to hear. You're in a unique position as a scholar, as an Indigenous scholar. You've had the opportunity to delve into the confluence of Indigenous ways of knowing and say more traditional academic psychology. Can you share with us one of those research aha moments or one of those nuggets that you've really taken away, something that you've discovered in terms of that confluence of Indigenous ways of knowing, traditional academia and psychology, and something that you've kind of brought together to really help move Indigenous people forward who are either struggling with addictions or mental health?
Yeah, there's a lot of them. Well, one of them was the story I told at the beginning about exposure-based treatments for anxiety. So that's one. That's one. Another one. Who here has ever seen a smudge or done a smudge? Anyone? Right. So in clinical psychology, one of the concepts that we know about is called emotion regulation. And what emotion regulation is our ability to keep our emotions within a range where they're helping to inform our behavior, but they're not making choices about our behavior for us. Does that make sense? It's sort of like, you know, you can be frustrated or you can be angry and you can feel yourself kind of be mad or get angry, but you keep your emotions in a place where you're not yelling or swearing or throwing things or acting aggressively or other things, right? So that's called emotion regulation. And so sometimes people can really struggle with that. And if you're really under a lot of stress or if you're really if you've really experienced a lot of difficulty, that can increase the likelihood that you'll struggle with emotion regulation. And so a lot of clinical psychology is in helping people regulate strong emotions, feel strong emotions, manage them through the moment, learn skills, how to cope, and so on. So that's called emotion regulation. The smudge ceremony is a lot of things, right? There's a lot of information in a smudge ceremony when it comes to the spiritual piece of it. There's also the practical piece. There's also the symbolic pieces and so on. But if anyone here has ever done a smudge ceremony, I think it is probably the most effective emotion regulation strategy of anything that I can think of, right? So even though the Anishinaabe people or the Cree people or other people who practice smudge may not have a word in the language like emotion regulation, there's a tremendous wisdom in understanding how to have a ceremony, have a practice that allows us to take our emotions, to bring them under our control, to orient to the here and now, and prepare our minds to carry forward in a good way. And so, when I began learning about underlying mechanisms and constructs in psychology, and then again visiting my own cultural experiences and knowledge, these are some of the real aha moments where it's like, oh yeah, we do that, and we do it really effectively. In fact, we do it, remarkably well, right? So yeah, it's a great question. Thank you.
All right, let's give a round of applause for Dr. Mushquash here for joining us. Thank you. Dr. Christopher, we just want to thank you for joining us today. We were allotted a half an hour, and we got 50 minutes out of Dr. Mushquash. Thank you so much for your presentation. I think it was just great I loved hearing your pathway into psychology, clinical psychology, through your journey and through your story. And I think that's just such an Indigenous perspective that is coming through in your research as well. And I know our students were really looking forward to hearing about the Indigenous perspective, the research that you're doing, and the impact that you're making, while at the same time sharing your story that these young men and women here have the capacity to move forward and consider making a difference in the lives of many individuals as well. And on that, students, you're going to see a post coming up shortly from Romer regarding a model school student who is currently studying at McGill, an Indigenous scholar who is just created a new course in Indigenous health, and I think in the area of epidemiology. Karen, do you remember? I think it's epidemiology, right? So, and it's Sarah Leggett. And so I encourage you to take a look at her story as well. She has a similar journey. She was, I think when she left us, she went to BC and she was going to study engineering. And now she's in the field of healthcare and bringing in Indigenous perspectives and Indigenous ways of knowing and learning into the field of healthcare at McGill. So take a look at that story as well. Once again, thank you for joining us. We have a small token of our appreciation from the Collegiate, and let's give a hand to Dr. Mushquash one more time.
Thanks again.